Interventional procedures for urinary stones. First is ureteroscopy. This is use of a laser electrohydraulic lithotripter or ultrasound to fragment and remove the stones. They may insert a stent for 48 hours or more afterwards, and this is done out as an outpatient procedure usually. Second is extracorporeal shockwave lithotripsy or ESWL. This is non-invasive. The stones are fragmented to grains of sand and then spontaneously voided, which may occur over 6 weeks to several months after the procedure. Post-lithotripsy, increase the fluids up to 3 liters per day. Hematuria is expected in the first few days up to a week. If stent is in place, hematuria is expected until it is removed. Take temperature every day and follow up with the doctor if fever is present and if increasing pain is not going away with analgesics. It is normal for a bruise to be present on the flank on the treated side of the back. Teach patients regarding signs and symptoms of complications, including infection, urinary retention, importance of follow-up exercises and being mobile, and monitor urinary pH to keep it acidic or alkaline depending on the type of the stone. Endourological procedure. If the stones cannot be removed by any other procedures, this procedure is done. A cystoscope is used and the stone removed or pulverized by the lithotripter. Percutaneous nephrostomy tube post-procedure is done to ensure ureters are not blocked by edema or blood clots. Complications include hemorrhage, infection, and urinary extravasation. Chemolysis. This is stone dissolution using infusions of chemical solutions like alkalizing agents or acidifying agent, depending upon the stone, via percutaneous nephrostomy, and this is used as an alternative treatment. Surgical management, 1 to 2% of cases undergo surgery. If the patient does not respond to any other form of treatment, or surgery is done to correct anatomic abnormalities or to improve urinary drainage by means of dilation or by putting in a stent or removing the stone. Urinary diversion. Urinary diversions are procedures performed to divert urine from the bladder to a new exit site, usually through a surgically created opening or stoma in the skin. Reasons for urinary diversions include bladder cancer or other pelvic malignancies, birth defects, trauma, strictures, neurogenic bladder, chronic infection, or intractable cystitis. This is used as a last resort for incontinence. Cutaneous urinary diversion is where the urine drainage is diverted to the skin. Examples are ileal conduit, cutaneous ureterostomy, vesicostomy, and nephrostomy. Continent urine diversion includes Indiana pouch, cock pouch, and ureterosigmoidostomy. Continent urinary diversions connects the ureters to a reservoir or pouch created from a portion of the ileum and cecum. A nipple-like valve is created which allows the client to self-catheterize the pouch after full healing and eliminates the need to wear a pouch over the stoma all the time. Ileal conduit reroutes the urine by connecting ureters to a tubular pouch created from a segment of ileum and brought to the skin surface to form a stoma. Urine drains continuously via the pouch. Vesicostomy is where the bladder is sutured to the abdominal wall for urinary drainage. In ureterostomy, the detached ureter is brought through the abdominal wall and attached to an opening in the skin. Nephrostomy is where urine drains through a catheter placed directly into the kidney. This is used when the ureters are blocked or damaged, may be temporary. It may be temporary. With the physician's order, the urine Flushes a nephrostomy tube with 5 to 10 ml of sterile saline with the help of a three-way stopcock towards the kidney to prevent blockage. The skin around the drain must always be kept dry, as leakage of urine to the skin can cause skin breakdown. Care of the nephrostomy is performed by the RN and may not be delegated to the UAP. Continent urinary diversions. Continent urinary diversions connects ureters to a reservoir created from a portion of ileum and cecum. A nipple-like valve is created, which allows client to self-catheterize the pouch after full healing and eliminates the need to wear a pouch over the stoma. Sigmoidostomies divert urine by connecting ureters to the sigmoid colon or to the tubular portion of the ileum. That is then connected to the sigmoid colon. Urine is eliminated through the stool, and no stoma is required. Nursing care. Reduce anxiety through pre-op teaching about procedure and what to expect after the surgery. NG tube, indwelling catheter or nephrostomy tube or the urinary pouch, Penrose drain or any other tubes and drains may be present after surgery. Address concerns about the alteration in body image and loss of sexual or reproductive functions. Postoperatively, monitor vital signs, lab results, hourly urine output and characteristics. Report hourly urine output of less than 30 ml per hour. Cloudy urine. Urine may be red or pink initially, that is expected, but must fade to a slight pink and clear by the third post-op day. Administer pain medications and antispasmodic medications as necessary. Urinary diversion and stoma care. Assess the size, color, and condition of stoma and surrounding skin frequently. Client teaching. Normal stoma must be pink or red and edematous initially. Slight bleeding during the initial cleansing is normal. A pale, deep red, purple, or bluish color to the stoma is abnormal. The stoma is not sensitive, but the skin around the stoma is sensitive to urine and must always be kept dry. Assess the skin around the stoma for irritation, redness, or inflammation, which could be due to the appliance bag. Observe for signs and symptoms of infection. Collection device must fit snugly around the stoma and should not be more than 1/8 of an inch between the stoma and the faceplate of the appliance. Cleanse the area around the stoma with warm water and pat dry. Avoid moisturizing soaps and body washes around the area to prevent problems with adhesion of the pouch. Do not use tape to prevent accumulation of urine under the skin barrier. Foods that cause strong odor to urine is avoided, like asparagus, cheese, eggs. A few drops of diluted white vinegar, oral ascorbic acid tablets helps acidify the urine and suppresses bad urine odor. Avoid using the bag longer than recommended. Drain the bag when it's 1/3 full. The reusable bag is rinsed in warm water and soaked in 3:1 water and white vinegar mixture or in a commercial deodorizing solution for 30 minutes. Air dry bags instead of in direct sunlight. Hot water and direct sunlight can dry the pouch and cause cracking. Bags can be air dried and powdered with cornstarch and stored.